in the practice of medicine on a daily basis, whether it be in your private practice, in an office setting, or in emergency room practice, you always face with several issues that sometimes borderline on what is considered ethical and what is not considered ethical in the practice of medicine. All physicians swear by the Hippocratic Oath, but a lot of times you're asked to review issues to base with the ethics in the practice of medicine. I will cite the case that happened over the last week in my practice in Richmond Hill, Queens, when a young woman, 15 years of age, or a child 15 years of age, or a teenager 15 years of age, presented to my practice with a brief history of 4 weeks of nausea and vomiting and anorexia, with increased frequency of urination over the last 2 to 3 days. In her mind, she thought that very much she probably had a stomach flu and possibly urinary tract infection since she was pregnant. To go over the scenario of this 15-year-old is, in retrospect, was someone who presented to another physician about 2 weeks ago. At that time, she presented with the same symptoms of nausea and vomiting, and at the time the physician thought that she possibly had a stomach illness and prescribed appropriate medicine for treatment of the stomach illness. He did not investigate whether or not this young woman could actually be pregnant. I don't think she actually volunteered that she was sexually active, neither did he ask her at that time, according to the patient. She was presenting to me as the third physician. She then presented herself to another physician a week later with similar symptoms. At that time, the physician diagnosed that this was a 15-year-old sexually active who was now been in 5 weeks pregnant. At the time, he spoke to her that she was pregnant at 15 years of age, that she should have the pregnancy, and he asked at that time, and this is anecdotal, it's only coming from the 15-year-old, is that he advised her to have the pregnancy since he did not believe in the termination of pregnancy. When the young woman presented to me, she presented with her mother at the time, not unknowing to the mother that her child was pregnant. The mother volunteered the history in her own perspective. And the history, according to the mother, was, Dr. Baldale, this is my 15-year-old girl. She's doing well in school. But over the last 6 weeks, she's been having nausea and vomiting, and she hasn't been looking herself. Would you mind to tell me exactly what you think is going on with her? And I mentioned that, first of all, we need to make sure that nothing is going on with the stomach, which is the most common cause, and see if there's any other causes outside of the stomach in terms of anything to do with CNS lesions can also present with nausea and vomiting, but also to rule out common things being common to make sure that she's not pregnant. The mother assured me her daughter is not sexually active, and hence there's no reason for even doing a pregnancy test. So basically, on those grounds, I pursued and continued what I think is diligent practice in medicine. I basically ruled out the common things, but also did a blood test to see whether or not there's evidence of pregnancy, and I informed her that that's what we're going to be doing. Having found out that we're going to be doing a pregnancy test, the daughter volunteered to her mother, much to her wrath and rage at that point in time, that she was pregnant, and she had gone to a physician and was told that she was pregnant. Then I found out the whole scenario as to exactly what took place. Prior to that, the mother asked me, basically, would you intervene and make sure and tell me whether her daughter was sexually active? And basically, I drew the line there as a father and as a practicing physician, that the bond between a mother and a daughter is much stronger than a patient and a physician. And as such, I will not involuntarily expose a child, a 15-year-old teenager, to a physical examination to prove or disprove sexual activity if the mother and the daughter cannot agree that they should be able to discuss freely sexual activity, and it's not up to the physician to determine whether or not there's a perforated hymen or not. And that is a definition of whether or not someone is sexually active in the absence of a sexually transmitted disease. So my retort to the mother at that point in time is that I will not examine your daughter to establish whether or not she is pregnant, she is sexually active or not. I will do a physical examination if it's warranted, based on the fact that you're having symptoms related to the pelvic area. but not to establish with a sexual activity. I think as a mother and as a parent, you should be able to keep that bond between yourself and your child, rather than have a physician step in between and say to you, yes, your daughter is sexually active, or no, she's not sexually active. Because I think once the bond between a parent and a child is broken by an outsider, and I consider myself an outsider, even though I've known these patients for probably the last 3 to 4 years, I think it's probably better for the mother and the daughter to establish between themselves whether or not there is evidence of sexual activity. This scenario points to 2 things. First of all, the initial physician did not do a proper exam or did not work up this young lady properly, or else he would have found out 3 weeks prior to that she was pregnant and the reason for nausea and vomiting. The second physician erred on the fact of imparting his own views on a 15-year-old. It is not our right to determine if anyone should continue their pregnancy or elect to have a termination of pregnancy. That is the sole right of the individual. And even a 15-year-old has that right, becoming an emancipated minor at 15 years of age, to make the decision for herself. Obviously, you want to be a part, if you're going to be part of a decision making between a mother and a teenager, and you've known them, hopefully your input is going to be to the betterment of the situation and not to impart your own values on it. My advice at that time to the 15-year-old is, you and your mom needs to go home and discuss the situation. You do not need to act on it today, but I think you should have a family discussion as to what exactly took place here. And if there's a reason for involving the potential father of the child into the discussion, then so be it. If it's the daughter's will that she should have a termination of pregnancy, by being an emancipated minor, she can make that choice. But it's so much better when that choice is made between the mother, the daughter, the father involved, the rest of the family, if necessary, involved, if they're going to be helpful in decision making. I know among our religious groupings in this community, and the belief that termination of pregnancy, and much so it's my belief as well, but it's not my belief to impart on you, it's my belief to keep to myself what I believe in terms of termination of pregnancy. Because that in itself is a massive discussion as to what the rights and wrongs of it, and I do not wear every shoes for every person. So I will not even think about telling you what my beliefs are. In this particular individual, it was elected that the termination of pregnancy, since the father of the unborn child was not someone who was worthy enough to be welcomed into their family. And that's their definition for the reason of termination of pregnancy. As far as I'm concerned, it is the only definition. Once the mother and the child are on the same page, then it's a win-win situation. If the mother and child are not, or the mother and the teenager, the emancipated minor, are not on the same page, then it's a win-loss situation, but it's a win for the emancipated minor, it's a loss for the mother, because it's only her thought process. What I did not like out of this situation was asking to step into the shoes of the person who's trying to decide whether or not I should actually be able to establish whether or not this child was sexually active. I thought the mother should be the one who should be discussing this with her child on a daily basis, and I'm sure she did discuss this with her child, because most of our Caribbean mothers are very, very particular. In fact, I have it as a joke within my practice that the mothers are probably aware more of the periods, the start and finishing of the periods, than the daughters are actually aware, especially when they're attending school. Anyway, this whole scenario just points to the fact of some of the problems that you face with in practicing medicine in Richmond Hill today. And I'm sure it probably is in other communities in other parts of our great country. Not too recently, about 6 to 7 months ago, I was passing through the emergency room. Having worked as an emergency room physician for the better part of my initial career as a physician in Jackson Memorial, which is a tertiary care university setting in Miami, and when I moved to New York almost 20 years ago, ran the emergency services at 3 of the hospitals within the neighboring area, it was not uncommon for me to experience quite a few instances in which the call of duty as a physician and the religious beliefs of the patient and the relatives sometimes conflicted. What happened a couple of weeks ago in the emergency room of a young woman who was involved in a motor vehicle accident with multiple injuries and multiple fractures and possible evidence of intra-abdominal bleeding, who was actually, when x-rays were taken, showed evidence of multiple fracture, and when CAT scan was done of the abdomen, had evidence of a liver spleen laceration and evidence of possible rupture of a viscus within the organ with evidence of abdominal bleeding. She had evidence of abdominal distension. I was called into the ER based on the fact that I recognized a relative standing outside, and I asked, "Why are you crying?" And basically she told me that her daughter was a patient, not her daughter, our niece was a patient, and in level 1 trauma room, and I just stepped inside just to see exactly what I could do based on the fact that this is someone I recognize as being a patient in my practice. The niece was the patient, the aunt was a patient in the practice, but the person who was injured was the niece. What I found out eventually when the medical aspect of it was established, that this was someone with hypovolemic shock as a result of multiple trauma and who needed to have a blood transfusion. But just realizing that the relatives were Jehovah's Witnesses, immediately the aunt told me that in no circumstance would they be able to transfuse her when I mentioned to her that there's a need for a blood transfusion ASAP. She was having normal saline infusion, and blood was being ordered on the spot prior to taking her to the operating room. I didn't think there was a reason for me to discuss this, but the remark was made, "Dr. Balde, weren't you aware that we are Jehovah's Witnesses? Why did you allow them to put blood transfuse? Why did you allow them to transfuse my niece?" I said I didn't allow anyone to do anything. I was not even part of the decision making. But what had occurred to me at that point in time, this was a person's religious belief as a Jehovah's Witness that they should not have blood transfusion. And I have nothing against Jehovah's Witnesses. What I'm referring to is that this was a life-saving move to transfuse a patient who is losing blood. You cannot transfuse with normal saline to replace blood. You can correct the hypovolemic shock momentarily whilst you wait for blood transfusion to be done, whether it be packed red blood cells or whole blood. But the treatment of choice has to be the transfusion of blood. And for this woman at that point in time to think of a religious belief above and beyond that of saving the life of her niece sometimes makes me wonder, what is the role of religion at that point in time? Was the religious belief was going to be to allow this person to die because you do not allow blood transfusion? I went back to the emergency physician at the time, the director of the ER, and said, basically, are you aware that this person was a Jehovah's Witness? At that point in time, there's nothing that matters to you in terms of religious belief. If you're making the right decision as a physician, that this is what needed to be done as a life-saving measure, I think all of us should be happy and not narrow minds to the simple fact that this was a life-saving procedure and now she's going to be tainted being a Jehovah's Witness because she's received blood. I hope at the end of some point in time God forgives whoever it is involved for transfusing blood to her. But I think if I were in the position of that relative, I'll be thankful to Almighty God for the saving of the life of that person, and hope that my religious belief will help me to tone down on my sins at a later point in time. And a lot of times in the emergency room, decisions like these are made. I remember a hemophiliac child who had to be transfused, and one of the parents refused it at that point in time. There's another matter that seems to be creating a lot of attention that I was privy to a couple of days ago that had to do with ethical practice of medicine. There was a patient of mine who needed a renal transplant, and she was on the transplant list to be done. Transplant in the United States, organ transplant, is a method of choice in which you ask as many relatives as you possibly can. In other countries that are not monitored properly, organ transplant can sometimes be bought. In the United States, it's unethical and illegal to be buying organs. purchasing of organs is an illegal transaction in the United States of America. The issue here was this particular family had actually procured a donor. The doctor who as the head of the renal dialysis center, who my patient attends, actually had her on the list for donor transplant, and she's been going and keeping her appointments. A very affable patient. Unknowing to her, a relative of hers had actually paid an individual. So when the doctors ask you, find as many relatives that you possibly can, who are going to be acting as donors, it's sometimes borderlines that you find as many persons who are as distant a relative as possible. And sometimes you may pay for that person to come to the hospital. Sometimes you might pay for the person to be tested. Sometimes you might pay for them because they cannot afford it to waste a couple of days off work. And sometimes there's minimal transaction of monies to assist that poorer relative who you're looking for a donor, an organ transplant to be done. In this particular case of this patient of mine, she needed a kidney. And her sons, who are fairly well off, had engaged every single family member they could find. Unknowing to the doctor at the time is that the fact that they had paid someone. So when the doctor was told that basically if he is going to be if he can pre-advance payment of some of the monies for the organ, he was as shocked as anything in his life because he was never part of that discussion. Neither was he privy to the private discussions with the relatives. Albeit the position that the hospital took was that the doctor was part of the transaction to procure an organ for this elderly patient who was a patient of my practice. The issue about that, all of it settled when it was found out that the relatives were the ones who were paying and not the physician who was running the dialysis center and who was trying to get her the transplant, thinking that he was doing the right thing, that this patient was getting a kidney from a relative. So in the practice of medicine, sometimes you're faced with issues that sometimes you think you're doing the right thing and you hopefully at all times will be doing the right thing. But you have to always be aware that sometimes when things arise, when differences arise, that the ethics and the practice of medicine leaves you with no other alternative but at all times to be able to tell the truth that you're doing the right things as much as possible. And over the next couple of series of talks, we will discuss some of the common things that we do see in the day-to-day practice of medicine. And I will give you some of the ideas of some of the things we see in the emergency room as well. That leaves a physician with some bit of something moral dilemma and ethical decisions to make on the spot, which sometimes have to be, can sometimes be made very simple if patients are sometimes prepared to volunteer more information that might be make decision making so much simpler, especially in our community at times.
Dr. Baldio Medical Services is located at 12507 Liberty Avenue in Richmond Hill. Dr. Baldio and Dr. McTrain board-certified doctors, each with 14 years experience in primary adult care and pediatric medicine. The facility is fully equipped to perform X-rays, EKGs, sonograms, stress tests, urine testing, pap smear, blood testing, minor surgery, weight reduction, and vaccinations. On-site evaluation done by surgeon, gynecologist, urologist, orthopedist, neurologist, psychologist, and eye specialist. So visit Dr. Baldio's office at 12507 Liberty Avenue, 718-845-8900.
Precious moments with G1's video production. We specialize in weddings, birthday parties, sweet 16s, TV programs, commercials, and much, much more. With all jobs professionally edited. No job too big, nor too small. Satisfactory guaranteed. Fully insured and bonded. Call G1 Singh at 1-347-623-9427.
Many a times during the course of the day in the workers' comp no-fault practice, you're asked to explain to patients why is it there is a correlation with the MRI findings and their symptoms. Or sometimes you get the question asked another way. Doctor, I'm having pain in the neck but it's only in the neck, and you're asking for an MRI to be done to establish if there's any evidence of nerve compression. But you know, I'm also having pain in the forearm. Could that be related to the pain I'm having in the neck? I'm also having numbness in the fingers. I was told I have carpal tunnel, but this numbness is over the entire hand itself, and also associated with loss of sensation over the dorsum of the hand itself. Could this be related to the lesion I have on the neck? I'm also finding that I used to be able to lift heavy weights, meaning over 20 to 30 pounds in the course of my work. Now I'm not able to do this. Could this be related to the loss of muscle strength because of the injury to the neck? Or is this by itself something that's occurring because of the injury to the shoulder? The answer to all of these questions is yes, yes, yes. And that's why sometimes you're faced with the dilemma of making the right decision. First of all, in your history, you try to put in perspective for that workers' comp or no-fault patient who's injured the neck and the back, which are the two most common regions of injuries that we see in private practice. That brings that patient to the physician. And that injury is reported, doctor, I was lifting a 40-pound bag and trying to lift it, I've injured my back. But you know what? Since then, I've not been only having pain localized to the lower back, but that pain now seems to be spreading to the buttocks area. And you know, last week it was restricted to the buttocks area. Now it's going down the back of the leg. Is the front of the leg involved? No, it's just the back of the leg. And I'm also getting a numbness over a portion of the leg at the front of the thigh. Could this be related to the injury to the back? Definitely it could be. And it's up to us as physicians to put it in perspective. Since my injury to the back, and it's only been recent, I'm having problems with erection. Could that be related to the injury to the back? Not directly, but yes, indirectly. I'm also faced with decreased strength in my lower limbs because of the fact of the injury to the leg, to the lower back. I had nothing to do with any injury to my knee, to my hips, or to my feet itself. Could this be related to the injury to the back? And definitely it could be. So in order to try and understand what goes on with injuries to the neck and to the back and how they affect the peripheries, meaning the upper limb or the lower limb, is to understand the anatomy of the spinal column and to also understand the anatomy of the brain and the spinal cord and the spinal nerve roots. In this diagram, we try to represent where the spinal nerve root is in relation to the vertebral column. We all are aware what the vertebral column is, which is the bones that make up the small facets of bones that make up the entire backbone. It is this that results in us having the dexterity of movement involving the neck, the thoracic spine, the lumbar spine. And if it were not for the fact that they were segmented, we will not be able to move them one on top of the other. We will not have the fluidity of motion that allows us to move freely. And all of us who have experienced stiffness to the neck or to the back really will appreciate the significance of why it is that we should keep the integrity of these little bones, the 34 bones that make up the back itself. First of all, we know the 7 vertebrae that make up the cervical spine, starting with the atlas and the axis, and the remaining 5 cervical vertebrae. The thoracic spine is made up of 12 thoracic vertebrae, the lumbar spine with 5 lumbar vertebrae, and the sacral spine with 5 sacral spine, but most of them fused, in fact S1 to 5 fused, and then the coccyx or the tailbone, the rudimentary tail in the Homo sapiens, actually becoming the fused bone. So we have the entire list of the 7 cervical 12 thoracic, 5 lumbar, 5 sacral fuse. And from each of these, starting with the uppermost part, you have a nerve root that comes out, a spinal nerve. If we look at the posterior aspect of the spine itself, looking at the spine in a cross section, and now looking at the posterior aspect, looking through to the back, we can see where the spinal nerve root comes out. We so happen to have 8 cervical spinal nerve roots, because obviously one is starting at the very top, and you have 7 vertebrae, so you have 8 nerve roots. And they all supply from C1 to C8, the cervical spine. But in order to understand what takes place is to visualize that out of each of these regions, which is the spinal cord, passing through the neuronal foramen of the cervical of the vertebral body, you can see the nerve root as it comes out. C1, C2, and they all have very beautiful names. And if you, in fact, you want to memorize them, you feel free to do it. I found it very challenging in medical school trying to memorize it, and even residency trying to memorize it, but it was important for exam purposes, and I still remember them because obviously I still need to practice medicine. But if you want to remember them, I don't think you need to, but let's just imagine that they're coming out as C1, 2, 3, and 4. C3 and C4 innervate the diaphragm through the long thoracic nerve of Bell. You don't want to hear that any further. The ones that are common to our patients are the ones that affect C5, C6, that affect the radial nerve that actually supplies sensation to the arm itself. The radial nerve, the median nerve, and the ulnar nerve. The ulnar nerve with C8T1 supplies this area of the arm. The radial nerve will supply the area involving the biceps, and the C8T1, the triceps. So any damage to the neck involving the brachial plexus, and here again looking at the diagram, the nerve roots as it comes out through the regions of C5, C6, C7, C8, and the T1, the first thoracic, forms the brachial plexus. And it's that brachial plexus that provides both sensory and motor power to the arm. So when you're looking at your MRI findings and you're seeing that there's evidence of disc prolapse or disc lesion or compression or possibility of compression of the nerve root, because the MRI will not tell you that there's a compression of a nerve root. The MRI will tell you that there is evidence of disc prolapse, and that disc prolapse, whether it be symmetric or asymmetric, will tell us whether or not you have credence to the fact that that nerve root is going to be more likely to be compressed on the right or the left side, depending on where the compression is taking place. If we know that a nerve root is occurring between C5 and C6 of the vertebral column of the spinal nerve root, of the spinal cord, then you know the likelihood of it causing weakness of the muscle, of the bicep muscles that's innervated by C5 and C6 is much more likely an explanation of that patient's condition. If you find that there's no evidence of C5 or 6 lesion, that is very unlikely that the weakness that our patient has experienced is related to the nerve root that is coming from the spinal cord. It's more likely related to either local phenomena involving the muscle or involving the shoulder, where the origin of the muscle and one of the tendon of its insertion, or the elbow. So then you look for another reason for this compression to be taking place. When you're faced with a patient who comes and say, "Doctor, I'm getting numbness involved in this area," and then you look and you say, well, basically you do not have any lesions involving any spinal cord compression that's in your report that says that you have evidence of disc disease or disc prolapse or osteophyte formation or any abnormality that can result in compression of that spinal nerve root involving C8 and T1, then you cannot extrapolate that to symptoms that you're getting from the MRI findings that is saying to you that there's a possibility of a nerve compression cannot explain the patient's symptoms. It must be, where else could this be happening? You can look behind the elbow. This is where the ulnar nerve runs that supplies innervation involving this area of the hand, involving this small finger. So that's why, as a clinician, you need to be able to look into your patient's symptoms, look at the MRI findings, and try and extrapolate, as I say, are the patient's symptoms consistent with the MRI finding? You can do an EMG or an NCV. An NCV is a nerve conduction study that can tell you whether or not that is evidence of sensory nerve conduction problems, whether it involves the sensory nerve related to a central position involving the spinal cord, or a peripheral position involving a nerve root on a distal extremity. The EMG tells you whether or not there's any motor deficit related to the nerve root of a motor nerve involving the arm or the leg itself. So these are methods we can actually use. So in response to my patients who ask me, "Doctor, you're reading the MRI, and the MRI results are saying there's evidence of this disease involving C5, C6, but I'm getting compression, I'm getting numbness involving my arm, involving my hand, and the numbness is just involving these three fingers and the thumb and the tips of the fingers. Could it be related to what I have going on in the C5, C6 lesion? Obviously no, because what this is reflecting is median nerve, carpal tunnel syndrome, median nerve involvement. And the median nerve is not supplied by C5, C6. The median nerve is supplied primarily by C7, C8, T1, with very small involvement of C5, C6. So here again, it's probably more to do with a peripheral problem than it is to do with a central problem, meaning involving the spinal cord. So this is how, as a clinician, you have to put in perspective your patient's symptoms and how it relates to the MRI findings, so you can actually be being able to make the decisions. Not the decisions are made for you. The MRI is just an adjunct for you to put into clinical perspective your knowledge as a clinician, as a physician, to say whether or not your patient's symptoms are related. You're not making the patient's symptoms fit the MRI. Your MRI is just used as a tool to find out whether or not your clinical suspicions can be validated by this test. If it is not, then what is the cause of those other symptoms? What I'm going to try in the next discussion is to go over in terms of how does this now relate to one of the more common problems that we see, which is involving back pain, and how the pain that radiates down the back of the leg.
Precious Moments, one's video production. We specialize in weddings, birthday parties, sweet 16s, TV programs, commercials, and much, much more. With all jobs professionally edited. No job too big, nor too small. Satisfactory guaranteed. Fully insured and bonded. Call G1 Singh at 1-347-623-9427.
Dr. Balladio Medical Services is located at 12507 Liberty Avenue in Richmond Hill. Dr. Balladio and Dr. Matrain board-certified doctors, each with 14 years experience in primary adult care and pediatric medicine. The facility is fully equipped to perform X-rays, EKGs, sonograms, stress tests, urine testing, pap smear, blood testing, minor surgery, weight reduction, and vaccinations. On-site evaluation done by surgeon, gynecologist, urologist, orthopedist, neurologist, psychologist, and eye specialist. So visit Dr. Balladio's office at 12507 Liberty Avenue, 718-845-8900.
As we continue our discussion on those injuries associated with neck and the back, albeit those injuries in the no fault in the motor vehicle accidents, as well as those related to injuries that we commonly suffer in the workplaces. And just to put it in perspective is that the axial and the appendicular skeleton. The axial skeleton obviously is the spinal column, the vertebral column here, with the clavicle and the scapula at the back, and the pelvis and the hip bones. I'll show you a diagram in which we can actually see how the appendicular skeleton, any injury to the appendicular skeleton, meaning the vertebral column and the appendages that come out like that, and the hip itself. So it's the clavicle, the neck bone. It has to do with the posterior aspect of it, the scapula, the acromion process, the coracoid process, and how it joins together to form the shoulder joint and the upper limb appendicular skeleton, which is obviously the forearm, the humerus, the radius, the ulna, the rest of the bones of the hands itself, and in the leg itself, the pelvis made up of the pubis, the ischium, and the ilium, and the femur, and the tibia, and the fibula, and the rest of the bones of the leg. The major portion that we send for MRI is involving pain involving the neck that radiates to the arm, or we having a diagnostic dilemma whether or not it's a pain that comes from the spinal column. And we did elaborate on a previous diagram what the spinal nerve roots look like and the way they come off the spinal cord with the spinal nerves. But just to show you the skeleton again, with the vertebral column, with the 7 bones that make up the cervical spine, the 12 bones that make up the thoracic spine, the 5 for the lumbar, and the 5 for the sacrum and the coccyx as well. Only fully well to understand that each one of these bones, except for the atlas and the axis, the atlas, however, holds the head, the skull upright, and the axis allows the rotation of the odontoid process of the atlas on the C2, which is this vertebral body. And obviously being cushioned by the cartilaginous intervertebral disc, obviously made up of nucleus pulposus and the annulus fibrosus. Nucleus pulposus is that thick capsule that keeps the gelatinous material that allows us to be able to cushion one bone on top of the other. It gives us the dexterity of being able to move our spinal column in such a way that we're able to bend and move. And when we get older and they're fusing, then we understand how much it is that basically we take for granted in terms of the mobility of these 34 bones that make up the spinal cord, the spinal column, and the importance of the integrity of this structure being maintained so that the spinal nerve roots, as they come through the neuraminal foramen, is actually maintained. In the event of you seeing evidence of a disc prolapse that causes compression of the nerve root, of the spinal nerve root, that's when you get a neurologic deficit. If it occurs for the cervical vertebrae involving C5, 6, 7, 8, T1, actually you have pain and sensation that radiates to the arm. When it involves the lumbosacral spine, which is involving L1, 2, 3, and 4, which are the most common areas that we involve with injury. Most of us looking on will possibly have a friend or a relative who's had sciatica, which is pain that radiates down the back of the leg, involving L4, L5, S1. And basically that patient will come complaining that they're having pain that radiates down the back of the leg. And basically we know that involves L4, L5. A lot of times we do an MRI and we'll see evidence that there is this disease or this prolapse involving L4, L5 with no evidence, with literally no evidence of nerve compression, because these are quite large openings. If we go back to the diagram that we had before, this is the sacrum, which is this bone, and look at the back. And a lot of times patients come complaining that I've got pain of the dimple of the buttocks area. And this is the sacral hiatus where, but below that is where the most common area of injury is, involving the area of the nerve root compression involving L5 and S1. The actual vertebrae that makes up the vertebrae of the entire spinal column obviously has a body, has the spinous process, the lamina, and into this vertebral foramen is where the spinal cord runs. And an unfortunate incident, I was looking at a football game the other night with the Navy and the Army, in which this gentleman in a wheelchair was brought to the young guy who actually had a transection of the spinal cord and became paralyzed during a game. And that transection, because he was no sensation from and able to move his arms, which means that C5, C6 especially was able to flex, but his level of transection was between C6 and C7, and he had minimal movements of his arms had no extension of his elbows because that involved C8 and T1. So you can look at the vertebral levels in which there's a transection of the spinal cord and see what is maintained. The fortunate thing for him, at least he had the C3 and 4 intact, which meant that the diaphragm is innervated, which means the intercostal muscles and the diaphragm were able to allow him to breathe without any external devices. So now that we understand what the vertebral body looks like, what the cartilaginous disc in between, and so always when we see a report that says disc disease between this area and this area, you try and extrapolate to see where is the disc disease and what is the nerve root that's being compressed, and how does this nerve root translate into the doctor making an interpretation as to which part what is the relevance of that nerve root compression. Let us look at this diagram and try and see how it relates to the one behind me, in which the patient is experiencing numbness involving areas down the back of the leg. The most common complaint that I have in my practice, and a patient who suffered injury to the lower back, is that patient who comes and say, doctors, now the pain is not only going to the buttocks area, now it's going down the back of the leg. Let us look at the nerve root. If it involves the thoracic nerve, the thoracic spine, then it will cause the spinal nerve roots to be compressed from the regions of the thoracic spine. When we look at the lumbar spine itself, then we can see that the areas that are affected. The areas of L1, L2, 3, and 4 is the anterior portion of the leg. And I'm going to show you that in a diagram, how that manifests itself. The ones involving L4, L5 involve this a massive nerve here called the sciatic nerve. And the sciatic nerve supplies a sensation down the buttocks area, down the back of the leg. If it involves the areas involving X1, which is the first sacral vertebrae, which runs through the sacrum here, you can look at the sacral, and you have a lot of nerve roots that form a branch that actually goes down to the back of the leg. This area is also responsible for erection and genital function within the area, and a lot of times we find when a patient has that area affected, they will complain of signs and symptoms of problems with bladder function, erectile function, but that's at an advanced stage of the disease process. Where the patients that I see in my practice, and most physicians will see in their practice, are the patients who have had evidence that shows that they've had S2, L4, L5, and S1 disease. That is a patient who will complain of the numbness down the back of the leg and increase in weakness in the leg itself. And this is how you actually, when we look at the MRI and we make the interpretation, this is what we're looking for. This is the lumbar vertebra. You can see L5 is written in S1. If the nerve root is being compressed between L4, L5, S1, then that supplies a branch all the way down to involving the sciatic nerve. If it involves S1 and S2, then you will get numbness down the back, the sole of the foot. And that's why it's an important question to ask your patients. Are you having numbness on the sole of the feet? Then you will know it's even involving the sacrum itself. Not that it's going to make too much of a differential diagnosis or a different method of treatment, but clinically it will put in perspective what is it that you as a clinician, how your interpretation of the MRI findings and how it matters to your patient. But it becomes more significant, however, at the point in time should your patient now complains of urinary incontinence, and now they are not able to control the passage of urine because the sphincter tone of the bladder is controlled by S2, 3, 4, the subpart of the sacral plexus. So the clinical significance of your patient complaining that, yes, I'm having numbness down the back of the leg. And if we look at this big diagram here, at the back here, we can obviously see this is the spinal column, the lumbar spine, with the sacrum, with this large sciatic nerve, and on a cross-section of it, you can see where the spinal nerve root comes out. In this particular diagram, attention is placed on evidence of nerve root compression. And let's go for the most common one. And this is the same diagram there. This, however, obviously is in a coronal section where they're looking at it posteriorly, and this is in a sagittal section. You slice the body down the midline, and you can see evidence of L4, L5 disc disease. And the darkened areas will show us where the numbness takes place with L4, L5. With L5, S1, you're getting numbness all the way down to the sole of the feet. if you have any evidence of this disease involving L2, L3, L4, you are going to have numbness down the anterior aspect of the leg itself. Not that this should be a lesson in neurology or anatomy, but it's so important the more you understand about how MRIs are interpreted, especially for those patients who are involved in workers' compensation injury, and also in addition to that, motor vehicle accidents, or those patients who've damaged their spinal column. Minimal amount of damage, but basically having some neurologic deficit, whether it be numbness or loss of motor function, increasing weakness, to see the relevance of having an MRI and how that assists in your care. It also will serve as an example as to why at times it's so important for your physician to spend the time explaining to you the clinical implication of that positive MRI finding, or the importance of a negative finding to make sure that those symptoms are not related. For instance, let's say that you had evidence of sacral plexus involvement involving S1, 2, 3, and you said the spinal nerve root is intact. Then obviously the bladder symptoms or the erectile dysfunction symptoms that you've gotten, that is being claimed as a result of the accident, will be negated by the physician who is doing the IME. So it's important for us now to figure out if there's another cause, and this is more important, as I did find it in the other day, that a patient of mine who's been on Actos who developed bladder cancer, basically his symptoms was a result of a lesion within the bladder and not because of the workers' compensation injury that resulted in injury to the lower back and the sacrum. So the importance of doing an MRI, it's not because it becomes due in a motor vehicle accident after 6 weeks and after failed physical therapy. It becomes due because the patient's symptoms warrant further investigation that was not established on a simplistic test like an X-ray. And your history continues to support the patient's finding that they have symptoms related to this disease involving a particular part of the spinal cord. And it's important for us to be able, as physicians, to say when we call for peer review, and with the new guidelines that are being created now with workers' compensation, it becomes so much more important for your physician to be aware of what is going on. It is important for them to understand the anatomy, the physiology, the neurology, and the relationship of whatever the patient's symptoms are, how it translates into what their complaints are as related to their back pain or their neck pain, and as it manifests itself to other end organs. Is there a bladder involvement? Is the chest pain you're having as a result of the intercostal muscles in addition to the neck pain itself you're having? Is the bladder issue or the erection issue or the problem with the sphincter tone of your rectum as a result of your injury? There's a very good friend in my practice who was pushed by a supervisor who has a transverse fracture involving his lumbar vertebrae and is having persistent chest pain. As a 38-year-old, he's having tremendous and profound erectile dysfunction. Basically as a result, not of the injury itself, but because of the significant amount of pain he's been having. But it's important for you to be able to say to that patient that if I relieve your pain, that you should be able to have some function return because it's not related to an injury involving the nerve itself. But the physician needs to be the one who's aware of what the patient's claims symptoms are, signs and symptoms are, how it is that his test has affected it, how the MRI, the EMG, the NCV, the nerve test, and how to tie it all together. Because the minute you call for a peer review, and I was saying this before, is that the new guidelines for workers' comp has made it so, it's become so draconian that it's now up to the physician to prove to that other physician on the phone who is working in the interest of the insurance carrier to deny all payments or as many payments as possible, to be aware of what he is discussing on the phone with the other physician who is trying to deny it. You're obviously in private practice, you're here on behalf of your patient, because if it were not for your patient, you will not have a private practice. And that patient that supported your private practice, they followed all your advice. They come to your therapy, they make sure they have all your tests done, And you are now in a position to tie those together so you can make an adequate representation to that other physician who's representing the insurance carrier and whose whole sole intent is to make sure that none of the bills are paid and that patient goes back to work and further damage themselves. They're not responsible. Their interest is only at dollars and cents value. They think of us, the physicians who represent the patients, as being on the side of the patient propagating a false claim, because that's in their mind that's all that happens to patients. In fact, when I was discussing on the phone regarding this patient who had an undisplaced transverse fracture involving L2 as to why he's having sciatica, my thing about it was to defend it to no uncertain terms that basically all his complaints could not be explained anatomically based on his lesion involving the lumbar spine L2. But if she were in a similar position to have an employer push her down a staircase to actually sustain a fracture, it negates anything else that the MRI shows. I will tell you the degree of injury to create such a fracture should be considered more than anything else as to why that person is having persistent pain. Because you do not get a fracture of a vertebrae by simply slipping and falling. You get a fracture of a vertebrae because you've sustained a tremendous amount of injury. So at times it depends on your physician who's there as your advocate to represent you and to explain to that other physician whose only intent is to make you seem as if you're lying on behalf of a patient who wants to stay home and fix the house and want to propagate treatment for an injury when in fact there's no legitimate reason to. If you are sound in your anatomy, your physiology, and your explanation as to the reason and rationale for doing something, then you can get on any forum to any physician, to any IME examiner, to any insurance carrier, and represent your patient to the best of your ability. For those of us who sit on the sidelines and want to represent our patients just based on MRI findings, then sometimes this is not the time to practice medicine. Because right now, in terms of even workers' comp and no fault, it is a battlefield to get approval for anything. But I'm not saying that the rules are wrong. It probably was predicated on the fact of the abuse in the past. But for those of us who are representing patients, and clinicians represent your patient, because the reason you're providing treatment is you think your patient deserves it, you think your patient actually is going to be benefiting from it, and it's the only method you can use. Obviously, if it doesn't work, you're not going to provide physical therapy for 2-3 years and tell me you don't have any other option plan should the physical therapy fail. But your option plan should be based on further investigation that are guiding you as to why you think your treatment has failed and how do you think you plan to make a difference. It all depends on how much interest your physician has, on how much intellect he has in terms of validating or negating what your signs and symptoms are. But more importantly, is for him and her to get on the phone or get on the podium or get basically on the witness stand and represent you as a patient. I think it's a duty of every physician, much more importantly today than it was in yesteryear when everything was approved the minute you send it in and you signed MD behind your name. Now, regardless of whether you sign MD behind your name, they still question you whether or not the legitimacy of your treatment. So it's important for us as patients to understand your physician is your advocate against the insurance carrier, but they're not negating anything that you're saying. It's just for us to prove to them that what we're saying is correct and what we're trying to do makes sense, both in terms of common sense and both in terms of medical sense.
Dr. Balladio Medical Services is located at 12507 Liberty Avenue in Richmond Hill. Dr. Balladio and Dr. Matrain board-certified doctors, each with 14 years experience in primary adult care and pediatric medicine. The facility is fully equipped to perform X-rays, EKGs, sonograms, stress tests, urine testing, pap smear, blood testing, minor surgery, weight reduction, and vaccinations. On-site evaluation done by surgeon, gynecologist, urologist, orthopedist, neurologist, psychologist, and eye specialist. So visit Dr. Balladio's office at 12507 Liberty Avenue, 718-845-8900.
Precious Moments with G1's video production. We specialize in weddings, birthday parties, sweet 16s, TV programs, commercials, and much, much more. With all jobs professionally edited. No job too big, nor too small. Satisfactory guaranteed. Fully insured and bonded. Call G1 Singh at 1 or 1-347-623 9427.
Most of us looking at this program would either have a complaint of a sleeping disorder or depression, either as a personal complaint or that of a very close relative. In the present economic hardship that we all are experiencing, trying to figure out how to manage when the day comes, sleeping at night becomes much more problematic. And I've seen larger numbers in my practice who have as one of either the primary or secondary complaint related to one or more forms of sleeping disorder. The primary complaint that I see in my practice is related to the fact, doctor, I cannot sleep. I've got so much in my mind. The minute I put my head on the pillow, in another couple of minutes I feel as if I'm drowsy, and then I'm up again. But I don't feel rested. I'm thinking about all the myriads of things I need to do, and all the things I'm unable to do, and all because if it were not for the economic hardship that we're faced with, I would have been able to achieve it. I would have been able to retire and go to Florida into the home that I bought, or I probably would not have had to just abandon the home in Florida and move back to New York. Lots of us are faced with similar stories based on the economic hardship. Others of us are faced with other issues related to personal problems in family which continue unabated, whether it be domestic or otherwise, whether it be accidental, whether it be due to illness. They're all problems that keep us awake. And in addition to that, the ever increasing taxes and ever increasing bills that we face with, sometimes we sit back and wonder how we're ever able to cope. When you address the issue of a stress disorder that's resulting in you not being able to sleep, your physician should not be automatically pushing his hand into his pocket and pulling out his prescription pad and writing a prescription. It should be much more an in-depth process. It should be related to things. What are the most common things that happen to you prior to you going to sleep when you experience these episodes of inability to sleep? Have you had a history of chronic sleep disorders, or is this something acute? What is the temporal sequence between whatever has occurred in your life or keeps occurring in your life that's resulting of you not being able to sleep? What are the other comorbid conditions that you have relating to your chronic conditions of hypertension, diabetes, high cholesterol, coronary artery disease, or the inflammatory bowel diseases, or the lung problems that is presently putting you on medications for controlling the symptoms? And what is the temporal sequence between you taking your medications? For instance, have you been on an antibiotic recently, like say for instance Levaquin, that keeps you up at night all the time? Are you on prednisone for chronic obstructive pulmonary disease that you take at nights that makes you very hyper and prevent you from sleeping? Are you that person who now goes to bed taking a cup of tea which you think which you think relaxes you, but it has caffeine, so it makes you much more irritable? Are you that person who takes nicotine before they go to sleep and expect it to make you feel comfortable, when in fact it can make you feel calm, relaxed, when in fact it's probably going to make you a little bit more hyper as you go to sleep? Are you that kind of person who just pulls out all the bills that they've seen for the day just before you go to sleep, just to remind yourself how firm and hard this economic hardship is, and it's not going away? Or are you that person who wakes up in the morning and says to them, let me pull out from my drawer all the stuff that I'm unable to do, that I was unable to do yesterday, that was so difficult because of all that I'm going through? Can I address them first thing in the morning when I'm up and about and full of energy, rather than towards the end of the night when I basically cannot afford to just be lying in my bed and looking at the ceiling and wondering where the next dollar is